This conference will now be recorded.
A very good morning to all of you. So today I'm going to discuss about benign diseases of vagina. So first, before going to benign diseases of vagina, first you have to know what is the normal natural defense mechanisms in the vagina. So there is normal biology of the vagina. So what is the normal biology of the vagina? So usually the vagina, the most common site for benign lesions like infections, ulcerations. So usually malignancies are very rare. So why? What is the defense mechanism that is in the vagina? So the skin of the vagina, that is the mucosa, that is, it is stratified squamous epithelium. So the stratified squamous epithelium has a very, it's a conified layer. The superficial layer is conified and it has no glands. It synthesizes mucus and there are no crypts in the vagina and the pH is acidic. It is acidic means it is 4.5. So why the pH is acidic? So the vagina under the influence of estrogen, so the dominant hormone, that is the estrogen, what does it do? The superficial squamous cells in the vagina under the influence of estrogen, okay, will convert the glycogen. So the glycogen is liberated from the desquamated epithelial cells. So usually continuously the superficial layer gets replaced. So it is desquamated, and in this superficial layer the glycogen is there and the glycogen is broken down and converted into lactic acid and hydrogen peroxide under the influence of estrogen and dodeline bacilli. So the lactobacilli, it's a gram-positive organism, and this gram-positive organism, lactobacilli, will, under the influence of estrogen, will convert the glycogen, which is liberated from the desquamated epithelial cells, into lactic acid and hydrogen peroxide, which is responsible for the acidic pH of the vagina, and it is a protective barrier in the vagina, right? So the mucosa, so it is the secretions of the vagina is white coagulated mucus. So this white coagulated mucus will have lactobacillus, the superficial squamous cells that are desquamated, so, and the transidate of the vagina. So usually the vagina, because I told you in the slide, it has no glands. There are no glands in the vagina. But how does the mucus form? I'll discuss. So you can see in this picture from down there, you can see the basal cells. There are 4 cells: basal cells, parabasal cells, intermediate cells, superficial cells in the vagina. So the basal cells you can see in the diagram. So these are the basal cells. So these basal cells, you can see they are large cell which are large nucleus. The nucleus is large and it is basophilic nuclei. And this is parabasal cells. These are immature cells, and this is more mature than this basal cells. It is parabasal cells. Okay, the parabasal cells are also large cells, but the nucleus is smaller than the basal cells. So when these cells are predominant, that means the estrogen is low. So when the estrogen levels are more, there are predominant basal cells and parabasal cells. So at what phases you will find low estrogen levels? Post-menopausal, after delivery, puerperium, that is lactation. So these are the phases where you can see more parabasal cells and basal cells. Next, coming to the intermediate cells. So these intermediate cells, you can see there are large cells. So they are very large cells. Then it's almost 5 times the basal cells. And the nucleus, you can see there is very small nucleus, vesicular nucleus. And next you can see the superficial cells. These are known as superficial cells, and this is responsible for the conified layer of the vagina. So there is conification index, you know. So the conification index will be more when the conification index will be more when there are more number of superficial cells. So when there are more number of superficial cells, when there is more amount of estrogen. So when the more amount of estrogen is there, you will find more number of superficial cells, right? So when you see parabasal and basal cells, I tell you low amount of estrogen is responsible. So when more, very vast number of parabasal cells are seen, that also implies that there is some infection and there is continuous shedding. So there is continuous shedding of the cells of the parabasal cells. That means there is infection, right? So what the components? So what are the components of the vaginal? So what are the secretions responsible for vagina? So vagina itself will not have any glands. So it is from the transudate. So vaginal transudate is responsible, and from the endocervical, and some come from endocervical and some come from the endometrial secretion. So the transudate of the vaginal epithelium and the conified cells of the desquamated cells of the conified layer. So these are the secretions, and the secretions of the vagina also come from the vulva. The vulva will have glands. Those are the sweat and sebaceous glands of the vulva, and also the specialized racemose glands of the Bartholin's are responsible for the secretion. And the characteristic order comes from the apocrine glands of the vulva. The Please don't talk. Vaginal secretors is provided by the apocrine. So normal vaginal flora. So what does normal vaginal flora contains? Most important organism is the lactobacilli, and you can find facultative organisms and anaerobic organisms. So these facultative organisms and anaerobic organisms, they are pathogenic. They are, when present in small numbers, they are non-pathogenic. So when they're present in large numbers, they become pathogenic. So it's non-pathogenic. So these are facultative includes Peptococci, Clostridium, bacterioids, Fusobacterium, and Candida. And anaerobic organisms are diphtherias, Streptococci, E. coli, Mycoplasma hominis, and Uroplasma urolyticum. So the beneficial effects. So when this normal flora, why it is important? Because they synthesize some of certain vitamins, and also they prevent the growth of harmful pathogens, and also play important role in the immune system, and they prevent colonization of the pathogens. So what is a physiological vaginal discharge? So physiological, I told you in the previous slide, it is physiological when it is non-offensive secretion. So there is no smell, and there is no itching, and there is non-purulent. So these are very important. Yeah, this word should be there: non-offensive, non-purulent. Okay, no itching, and also this physiological vaginal discharge, they varies with the menstrual cycle. So where more amount of vaginal discharge will be there at the time of ovulation, and just premenstrual. So these are the two phases where there will be more amount of secretion. It contains sweat sebaceous glands, Bartholin, apocrine secretions, sweat sebaceous glands of the Bartholin, and apocrine secretions, which are responsible for the odor. And most important is the transudate, vaginal transudate desquamated cells of the conified layer from the cervix, from the endometrium, and from the tube. So these are the secretions of the vagina, normal vaginal discharge. So what is now, we have finished what is normal. So when you know normal only, you can know what is abnormal now. So what is abnormal? So abnormal is, it can be physiological. So physiological abnormal means abnormal is the amount. So amount we can classify as moderate. Suppose if you use the term moderate, that means the discharge will stay in the underclose and she needs frequent changing and washing. That is the term you use when you use moderate amount of vaginal discharge. So when you want to use excessive vaginal discharge, that means the patient has to keep an extra absorbent pad. So that is termed as excessive vaginal discharge, and it is genuinely pathological usually, but sometimes this excessive vaginal discharge also can be normal. So like in physiological conditions and leukorrhea. So physiological conditions are during puberty because of more amount of estrogen, and in pregnancy, and ovulation, and premenstrual and sexual. So these are the conditions where you can see physiological increase of vaginal discharge. And this term is very important, leukorrhea. So leukorrhea, you can term leukorrhea is when it is non-pathogenic. There is increase of vaginal discharge, which is normal. That is, there is leukorrhea is non-purulent discharge. So the word leukorrhea should be used when the normal vaginal secretions, when they increased in amount. So when the normal vaginal secretions are increased in amount, it is non-purulent, and there are no leukocytes because there is no infection. There will be no leukocyte. That is why it is called leukorrhea. So leukorrhea can be because of vaginal causes and can be because of due to cervical causes. And um, so other conditions where you can see increase of vaginal discharge, simple, when there are vascularity of the pelvis is increased, like chronic congestions. When the congestion is increased, in case of PIDs, in case of cervical polyps, or suppose if there is prolapse with a hypertrophied cervix. So when there is prolapse in hypertrophic circle, there is increase of vaginal transudate. So there is increase of leukocytes. So this is a mechanism. And in case of chronic constipation, right? So these are conditions where there is increase of vaginal discharge. Coming to the pathology. So you term pathological when there are infections. Infections, we know, because of presence of vagina. So I told you it is non-purulent, non-irritant, and non-offensive, and not associated. So you want to term as leukorrhea, you have to fulfill this following criteria. That is non-purulent, non-irritant, non-offensive, and not associated. What are the causes? I told you any cervical erosions, cervicitis, polypectropion, and vaginal cause acute retroversions. Acute retroversion, chronic period, and chronic constipation. Okay. So you can see here diagrams. This is a where this is chronic cervicitis, where you can cure. So different conditions will have specific treatment. So for chronic cervicitis, the cryo or laser diathermy you can use and treat the patient. And the patient complaining of discharge will decrease. And if you find erosion, so here you can see upper lip, there is erosion here. And here also the treatment is specific, that is cryo laser diathermy, the vaginal discharge will decrease. You can see from the external laws, you can see the pressure growth of thing produced. This is nothing but a polyp. Just if you remove it, the discharge will decrease. And this is an ectropion. You can see this is an ectropion. So, or this is tracheorrhea is a treatment. So, if you reassure the patient and if treat underlying cause, the vaginal discharge will decrease. So, these are the causes for leukorrhea. So, these are the cervical causes of leukorrhea. Next, coming to the vaginal causes of leukorrhea, you can see these are the uterus tubes, and there is pelvic inflammatory disease here. You can see a chronic condition, that is vascular, and this is acute retroversion. You can see that this is anteversion. Anteversion is, this is the axis. It is turning forwards. When it is done backwards, it is retroversion. And this is chronic constipation. Please don't talk, students. Somebody is talking. Okay. Okay. Sorry for the interruption due to power cut here. So we'll continue now. So these are the vaginal causes which causes leukorrhea. So pelvic inflammatory disease, acute retroversions, pelvic congestion, and chronic constipation. So when you correct all of this, the patient's complaint of vaginal discharge will decrease. And I just forgot to tell you in the beginning, this is very important slide. Yeah, this one. So he told you the acidic T because of it is because of duodenal bacilli, the pH is maintained between 4 to 4.5. As the acidity of the vagina falls, when the vaginal pH falls, the protective mechanism fails and the pathogens will be able to thrive there. So depending on the different phases in life, the vaginal pH changes. So at newborn, it is about 5.7. And in children, so first 10 days of life, it will be more acidic. Why? Because it is passive transfer of estrogen from the mother. First 10 days of life in the newborn, the pH will be less. But after 10 days, again, the pH will increase. That is 5.7. In children, it will be 6 to 8. And at the time of puberty, where the estrogen will be more, the pH will be 4. During pregnancy, pH is 4. And in menopause, where the ovaries become atretic and the estrogen level falls, the pH becomes alkaline, towards alkaline, and it is 7. So what are the factors which have increased risk factors, that is rise of pH, that is before puberty and during menstruation? So during menstruation, what happens? All the endometrial secretions comes through the cervix into the vagina and come out here. So the pH will be alkaline. And after abortion, so after abortion and labor, same thing, the lochia will be there, and after abortion discharge will be there, that is from the endometrium, so it becomes alkaline. And excessive vaginal discharge because of infection. And after menopause are the risky factors where there will be chance for the organisms to invade because of the increased pH. It is due to alkalinity, right? Next, what are the infections? So leukorrhea we have completed, and you should know what are the infectious causes which can cause vaginal discharge. This is a commonly, maybe you have completed this chapter, different infections. So just briefly, I'll just go through what are the infections. So bacterial vaginosis. So bacterial vaginosis, the bacteria responsible are most commonly Gardner's vaginals and Mycoplasma hominis. And here there'll be fishy odor or the musty odor, and there will be homogeneous vaginal discharge from gray to white to yellowish. And here the pH is greater than 4.5. I told you when there is alkaline pH, the organisms invade. And in microscope, you can see in this diagram. Okay, this is a bacterial vaginosis, and you can see here this is a vaginal cell. Okay, and here you can see the vaginal cell is studded with the bacteria. So this is when the vaginal cell is studded with bacteria, it is called as a clue cell, right? So there is a criteria for bacterial vaginosis. So to confirm the diagnosis of bacterial vaginosis, or to you should fulfill this criteria. So when this criteria, at least 3 out of this 4 criteria present, you can say that the patient is having bacterial vaginosis. That is, one is a homogeneous vaginal discharge, the pH is greater than 4.5. That is, you will have a litmus paper like thing, and when you put the vaginal discharge on the paper, depending on the color, you can say it is alkaline or acidic. So the pH is greater than 4.5, and as I have shown in the previous slide, there are clue cells. So the clue cells on Metmont. So you can find clue cells on Metmont and Gram-Stein. So next one is the positive whiff test. Positive whiff test is nothing but when you pour some KOH on the vaginal discharge, there will be liberation of a fishy odor, amylang odor, due to liberation or release of cadaverine, putrescine, and trimethylamines. So when these amines are released, the typical fishy odor comes out. So it is called as a positive whiff test. And treatment is metrogynon or clindamycin. Next, another type infection most commonly is due to vulvovaginal candidiasis. So vulvovaginal candidiasis. So most common is Candida albicans, and there are predisposing factors, as all of you know, during pregnancy, during diabetes, obesity, immunosuppression, ossifils. All these are factors responsible for Candida infection. And how the patient present to you? There'll be pruritus, soreness, dyspareunia, external dysuria, and vaginal discharge. Typically, the patient will be suffering. And when you examine on clinical exam, you can find it thick, adherent, and there is no odor, there is no smell. Curdy white, you can clearly curdy white or cottage cheese discharge. Here the pH is acidic. So typically the infection where occurs when pH is acidic also is Candida. Candida, very important bit. So in this diagram you can see typical curdy white discharge of cotton cheese appearance you can see here. Okay, and these are the mycelia, that is pseudo hyphae mycelia. So these are typical of a, what is that? Candidal infection. So you can diagnose in colonies. You can see this creamy white colonies and dark black colonies. So these are the colonies where you see in candidal infection. Okay. So fluconazole and clotrimazole are the treatment of choice. Another infection is trichomonas. So trichomonas typically, what is it is called? It is how it is looking like. It is a strawberry cervix. So typically strawberry cervix is seen in trichomonas vaginalis. So it is a protozoan and it has a flagellae, right? You can see the diagram. It has a flagellae. So it is motile. So usually it is transmitted from fomites, swimming pools, bathtubs, and the patient presents with you with foul smelling discharge and it is frothy yellowish green discharge with or without vulvar irritation. It is called a strawberry cervix. So typically diagnosis by culture, Feinerberg Whittington media, Kupferberg's media, and Diamond media. So this is the culture and treatment is with metrogyl and tenelidzine. Next infection is gonorrhea. It is a gram-negative diplococci. We can see diplo. So two cells are there, no? Two cells. These are nothing but a diplococci. And the patient typically presents with lower abdominal pain and intermenstrual bleeding and dysuria. So there will be odor or some mild odorous discharge and mucopurulent discharge, and it is very thin. And typically the patient will have tender cervical wounds. So when you just do a pervaginal examination, you can see this when you do the cervical movements are tender. And the diagnostic tests for gonorrhea are Thea-Martin medium, colloid medium, and chocolate agar medium. Okay, other confirmatory test is NAT test and PCR test. You can confirm. Treatment is cephalosporin is the treatment of choice. Ceftriaxone 250 mg IM brings 1 gram oral start. You can give. Suppose if the ceftriaxone is not available, you can just give in a oral form, that's affixing 400 mg per oral plus azithromycin 1 gram per oral start you can give to the patient. Suppose if the patient has pencil energy, you can give gemifloxacin, okay, or with azithro, or you can give gentamicin with azithro. And next is chlamydia. It is mostly a coexisting. So usually all the infections, so usually sometimes, many times you see mixed infections. And chlamydia, there is odorless mucoid vaginal discharge and there is no pruritus. Odorless mucoid vaginal discharge and there is no pruritus. Cervix is yellow, cloudy discharge from the os. Here typically the cervix will bleed on touch. Okay, you can see that there are chlamydia trachomatis. Treatment is again most common treatment azithromycin, doxycycline 100 mg per oral bleeding to 7 days. So sometimes or alternative treatment is erythromycin. So this erythromycin it can be used in pregnancy also. So 100 mg QID into 7 days. So here is just a representation of the variety which is most common is vulvovaginal candida, trichomonas, and Gardnerella vaginalis, that is bacterovaginosis. So most common organism is because in vulvovaginal candidiasis, Candida albicans, and next Trichomonas, okay. So this is protozoan Trichomonas vaginalis and Gardnerella. Bacterial vaginosis is usually caused by Gardnerella vaginalis. It's a mixed infection. So many organisms will be there. And main symptoms in case of candidiasis, patient will have pruritus. So itching, she'll have more amount of itching. And in case of trichomonas, the patient will have profuse discharge. Okay. And in case of Gardnerella, it will foul smelling. Usually the foul smell, fishy smell is in case of bacterial vaginosis, profuse in case of trichomonas. And per speculum, if you see, curdy white discharge I have shown you in the previous slide. And here, strawberry cervix and greenish yellowish frothy. So frothy is a word used for trichomonas. And for bacterial vagina, thin grayish homogeneous vaginal discharge. And how do you confirm? So on KOH, if you put a KOH on the vaginal discharge, all the debris will get dissolved and you can see hyphae, pseudohyphae, mycelium spores in case of candidiasis. And you can, when you see a wet mount perforation, you can see motile protozoan which is larger than a leukocyte. And the clues are typical. That is one of the criterion Amsel's criteria is clue cells that is typically present on wet mount you can see, or in a gram stain you can see in case of bacterial vaginosis. And when you want to do a culture, so usually we don't do cultures in our hospital, because we just by clinical examination and by wet mount you can confirm and then you can start your treatment. But for theory's sake, you have to remember culture. So I, in the previous slide, I've showed you, white colonies and black colonies. This one. So this is white colonies. You can see in Subarodes dextrose agar medium for candidiasis, and in Nickerson medium there are dark black colonies. So Nickerson medium you find dark and black colonies. In Subarodes dextrose agar you find creamy white colonies. Okay. And this is a media which is used for trichomonas, Finberg, Wittenton's media, and Kupfer media, and diamond media. And this is amine test. I told you when you put a drop of 10% KOH, there is liberation of amines, that is putrescine, cadaverine, and trimethylamine, which is typical, will produce a fishy odor. That is the WIP test you confirm, right? And treatment. So you have general measures and the specific. So general measures for same for all the three conditions. The general measures are treat underlying cause of diabetes days, antibiotic use, local hygiene, abstinence, avoid synthetic condoms, and you have to treat sometimes partner also. Okay, so treatment I've showed you in the previous slides. Next, coming to the inflammations of the vagina. So inflammations of the vagina. So what are the conditions which can cause inflammations? So inflammations of the vagina can be caused by chemicals, drugs, douches, pessaries. So pessaries are usually used for prolapse patients. Okay, sometimes for retroverted uterus, you use pessaries, no? So those pessaries you forgot. Then they cause inflammation and tampons and trauma, foreign bodies, sometimes contraceptives, vaginal and cervical operations. So what are the symptoms of inflammations of the vagina? So why this is inflammation? There is because of alteration pH. There is alkalinity of the pH is increased. So that favors the infection and most common in the puerperal period. So what are the symptoms and signs for inflammation of the vagina? So the patient will have typically, she'll have red, swollen, tender vagina, and there'll be irritation, there'll be burning, there'll be dysuria, and there is increased frequency of maturation, and amount of discharge depending on the infection, it varies. So diagnosis by smear and culture of the vaginal discharge. So treatment is you have to improve the health, and there's some vaginal jellies are available in the market, so that that is by a disposable applicator. You just introduce that into the vagina and just drop the jelly there, so that there will be correction of vaginal pH. So that vaginal pH, it's a water dispersible, so the correction of vaginal pH to 4.5. And that we have, and also some creams will be there that includes the sulfur compounds. It is triple sulfur antibiotic. Pessaries will be there, so that they will increase the pH to 4.5. So the immunity is maintained, and the SD pH is maintained, which will clear out the organisms. And whether a chronic cervicitis, you can just clear the infection by using a diathermy cauterization or conization. And non-specific vaginitis. So after giving this, you can give kits like combination of these three drugs, that is fluconazole, azithromycin, and secondazole, stat dose. You can give to the patient. So when you give a one-day therapy, you can give, or a combination. Combination means you can give doxycycline for 10 to 14 days. So for gonorrhea, you can give cefixime tablet. So advantages of using such a combination, it avoids detailed diagnostic workup. So this is repeated a week later if required. So if it's non-specific vaginitis, so vaginitis A, you can do combination drug so that there is no detail necessary for detailed workup for this, because all these investigations are cumbersome. All the because culture, so culture will take time, no? So you can just treat non-specifically with drugs combination like fluconazole, azithromycin, suppose if they are not okay, or a suspecting gonorrhea, you can start suffixin doxy, right? So suppose if again the patient comes, you can repeat the course 1 week later also if required. Then coming to senile vaginitis. So senile vaginitis most commonly is due to because of estrogen deficiency. So senile vaginitis is because of estrogen deficiency. When there is estrogen deficiency, the vaginal epithelium becomes thin. The vaginal epithelium becomes thin and atrophic. So the vaginal epithelium becomes thin and atrophic, and so that the glycogen content is not there, because from the superficial conified layers the glycogen content is less, there is no bacilli, so the bacilli will be less, glycogen contents will be there is no conversion to lactic acid and hydrogen peroxide, that is why there is pH will be alkaline. So because of deficiency of estrogen, everything happens. So what is etiology? Menopause, prolonged lactation, premature menopause, oophorectomy, the conditions where it can produce senile vaginitis. So what are the symptoms? The patient will complain dry vagina, there is no mucus secreted, no, and there is dyspareunia because of that, and because there will be purulent bloody discharge. So blood tinged discharge will be there, and there is increased frequency of dysphoria. And the mucosa will be excoriated, will be tender sometimes, and there will be pouting urethral meatus, and there will be vaginitis. There is patchy granular vaginitis will be there. So there is patchy granular vaginitis and spots of which are red. So there will be patchy vaginitis will have red spots which bleeds easily on touch. And because of this, sometimes because raw areas will be there, they'll get adherent to each other, and they can cause obliteration of the canal. So when there's obliteration of the canal, what will happen? There will be accumulation of all the secretions there, and it causes pyometra and pyometritis, and that will cause endometritis also. So senile vaginitis can produce senile endometritis when there is obliteration of canal and there is pyometra. So when you don't treat, it can lead to pyometra. So you have to treat. So what is the treatment? Because I told you it is because of senile is because of estrogen deficiency. What is the treatment you have to give? Estrogen, so to increase the vaginal pH and for the healing of the vaginal epithelium which was thin. So what is that? You should give an estrogen in the form of ethylene estrogen 0.01 mg for 3 weeks. You can give 1 week off, or you have vaginal estrogen creams will be there. So you have tablet forms, you have cream in pessary or ointment forms you can give. Okay, which will raise the glycogen and will lower the pH. That is the treatment. And what is secondary vaginitis? Secondary vaginitis is the pathology, or the primary is not, the cause is not in the vaginitis, because of secondary reasons there is infection in the, or there is inflammation of the vagina. So there is foreign body because of vaginal pessaries, because of treatment in the prolapse or a retrovated uterus, and contraceptives, tampons when used for prolonged periods, and then there's infection conditions of the cervix. So when there is endocervicitis, cervical trace, because of that there will be increase of vaginal discharge, and there will be because of fistula formation. Suppose there is vesico-vaginal, or there will be vesico-vaginal or uterovaginal urinary fistula, rectovaginal fistula. What happened? There will be infections and cause persistent discharge. And fistulas also the patient will complain of. So here in the slide it is not written, but the fistulas also are an important cause, secondary causes for the vaginal discharge. And carcinoma cervix, and then this growth of the cervix. Vaginitis medicamentosa. What is vaginitis medicamentosa? Medicamentosa is because of some medicines, like medicamentosa is caused. This is a type of vaginitis which is caused by arsenic products or douches and occasionally pills. Then you term it as vaginitis medicamentosa. Next is emphysematous vaginitis, is very rare. Here the vaginal wall will be distended, which contains gas containing vesicles, and indurated, but no ulceration. So it gives a typical feel of some carcinoma because there is indurated. So indurated is usually a feature of carcinoma, but it is not carcinoma. It is emphysematous vaginitis. There will be no ulceration. So usually etiology we don't know, unknown, and usually occurs in pregnant patient. The patient will have profuse discharge and swollen vagina. And next, how do you treat? So you have to treat the irritation of the vagina. So antibiotics like betadine and actifavin you can use in the form of pessaries. You can use estrogen containing things and antibiotics, steroids, antifungals, okay, bactericidal creams. All these are you can use for vaginitis. Coming to ulcers in the vagina, it is very rare. So ulcers in the vagina are very rare. So there'll be foreign bodies which cause ulcerations in the posterior vaginal wall, and unhealthy offensive discharge will be present, and there'll be following long standing irritation. Ulcer may undergo malignant. So when you find ulcer, you have to treat it because a long standing ulcer can lead to malignant transformation in a later stage of life. Okay, there'll be venereal ulcers also can be there. Usually the venereal ulcers are most commonly involves the vulva. Rarely they involve the vagina. And there'll be tuberculous ulcers also very rare. But isolated tubercular ulcers will not be present in case of vagina. They'll be also commonly present on the vulva and cervix. Okay, isolated will be rare in the case of vagina. So these are venereal ulcers, tuberculous ulcers, chemical ulcers because of potassium permanganate, pessaries cause. They cause ulceration and cicatrization and stenosis of vagina. And radiation ulcers, so common treatment for carcinoma cervix is radiotherapy when they stage exceeds stage to B. So in case they are sometimes they cause radiation ulcers. They're very difficult to treat. Radiation ulcers are very difficult to treat. And trophic ulcer, they're observed most commonly in procedentia. So procedentia is fourth degree prolapse. It is complete prolapse. So we over the almost all the uterus with the whole of the uterus there is eversion of vagina and the cervix will be outside, no. So what happens there, constantly it is get exposed to the environment, and there will be dependent part, there will be ulcers, so that is called as trophic ulcers. Amoebiasis, so these are just, you remember that amoebias, they are very rare. Fungating subcutaneous ulcer, foul smelling discharge, and patients most commonly come with post-menopausal bleeding. So when you take a biopsy, it confirms, and it's very easy treatment. Just with metrogyl, the vaginal ulcer will resolve. And coming to the cysts of vagina. So cysts of vagina, they're very rare, most commonly on the anterior vaginal wall. So your Gartner's, I think you heard of Gartner's. What is Gartner's duct? What is Gartner's duct? You know, the Mullerian duct, is resorbed or they regresses in a female. No, in female, paramesoductal will develop. That is Mullerian duct or paramesonephric duct will develop. So the mesonephric duct will regress. So there will be sometimes in the process of regression, there will be remnants of this Mullerian duct that is called as Gartner's.
This conference will now be recorded.